Let's get straight into it.
Ah,
Am I muted? No. Hello. It's always awkward when I say, am I muted? Right in the beginning of a streaming webinar. Thank you, everybody, for waiting. My name is Dr. James Tran. On behalf of General Dental Residency, we have a special guest, Dr. Cecilia So, doing the first of our free webinars for 2026. Dr. Cecilia So is here to present on the topic of your very first implant. She's an oral surgeon practicing in Sydney,
mm.
and so if you feel free to reach out to her if you want to send her a message or if you have any questions if you're in the area. Um, Dr. Cecilia So, I will leave it to you, and we'll get right into it.
Okay, thank you. Just a minor correction. I'm actually a surgical dentist. My registration is a general dentist, just like you. So when I lecture, I
Okay.
always say I'm registered as general dentist, just like all of you. Whatever I can do, you can do. This is all within limits of a general dentist. I haven't done general dentistry for about 15 years. So my practice is specifically limited to oral surgery and implant dentistry, both surgery and restorative. Okay. So thank you very much for the invitation, James. This free webinar is part of a joint collab to also advertise to you and encourage you to join ITI Congress. I'm presenting in Melbourne, 4th to 6th of June. The title of the Congress is Future Frontiers, powered by Teamwork and sponsored by ITI. So hopefully you've got some time free and I can see you in Melbourne where there's international speakers and as well as myself presenting. So let's get on with your lecture today. So tonight it's about your first implant. Now, I'm sure many of you have progressed past your first implant, so thank you for coming anyway. But this is basically a summary in an hour of treatment planning, how to communicate to your implant patient, as well as the basics, just implant 101. Okay. So, what are dental implants? Dental implants are a medical device. We use this medical device, which in Australia has to be TGA approved, to replace a missing tooth. It can also replace a tooth that we have deemed is irrational to treat, so either or. But this is the key. A missing tooth is replaced by an implant. A tooth that is restorable, most of the time, generally speaking, we prefer a tooth over an implant. Okay, so if you can restore a tooth with root canal treatment and a crown, especially in a younger patient, it's slightly different if they're older. You can have pros and cons either way if they're slightly older, but always try to restore and save a tooth if you can and give that tooth a 10-15 year life before you go to implants. We are generally replacing teeth with implants only when it's irrational to treat, or we are unable to basically either it's not suitable for a root canal or restoration or so forth. They can look very natural, as you can see this 2-1 restored by Dr. Gordon Howe and placed by me. The only people who know are the dentists and the patient. No one else. That's the whole idea. It's something natural that the patient forgets about, basically. They still have to maintain it, obviously. So remember, in that point of view, from a daily point of view, they can just forget that that's an implant. Now, the benefit of an implant versus a traditional 3-unit bridge is that in the literature it's been found to be more cost effective. Biologically, it's also more effective because you're not having to crown 2 virgin teeth on either side. So there's no need to like touch the virgin teeth, which we call abutments, on either side of your missing tooth. It's a standalone device that is going to help you restore function, aesthetics, occlusion to your patient. So your implant itself is actually a titanium fixture. So you can see from this diagram here, you've got your titanium fixture. We call that an implant. We've also got an abutment, which is joining the crown to your implant, and finally you've got your crown. So there are two different types of implants I'm showing you here. One is tissue level, so the implant is at the level, is inside the bone, but the crown is restored at the level of the tissue, so the soft tissue here. And this one is bone level, so the implant is at the level of the bone with the abutment, which you can see there, and then your crown. So this you can see here. Okay, so you've got your three parts: your implant, which goes into your bone, your abutment, which is the connection, and the crown, which is the joining between your implant and your crown. So your implant fixture is basically the structure that goes inside that helps you restore your missing tooth. So the patient selection criteria, now this is very important. As a clinician, we have to balance our own skills, our judgment, the patient's risk, so that could be dental factors, medical factors, anatomical factors. Smoking is a big factor in implants. We have to then pick our treatment approach, and this could be, hopefully for you, a simple case first, and then you can move on to advanced and complex. And then biomaterial. So that would be your implant or your bone graft or what kind of crown you're going to put on your tooth. So those are all decisions that you need to make as an implantologist, basically. What are the patient factors we have to be aware of? So uncontrolled diabetes, because that increases risk of infection for your implant patient. So generally speaking, I will say no to anyone that has BSL or HbA1c that is not controlled or quite high, say 9, 10, 11, 12, 13, 14, I would steer quite clear of. I will tell the patient to go to the GP and come back and let me know when it's well controlled. You're basically putting the patients at risk of an implant failure and putting yourself at risk of having to manage a complication. The second is head and neck radiation. The third would be smoking patients. Poor oral hygiene is a big factor as well, so that will increase the risk of your implant failure. Patients with a history of periodontal disease, so bleeding on probing more than 25% of sites, probing depths of more than 5 millimeters. So these patients with periodontal disease, even if you remove all their teeth, right, the bacteria is still in their tongue or still in their cheek or still in their saliva, and then you place an implant, which is a smooth surface, the same bacteria floating around the mouth is going to then affect that implant. So then you would get peri-implantitis, which is a common complication to implant therapy. We're looking at about 25% of the implants placed. So it's quite high. All right. What other patients to really, for me, I would suggest that you avoid for now. Say anticoagulated patients, you really warfarinized patients, you've got to be really careful about. Make sure you are comfortable with managing them. Osteoporosis and bisphosphonate therapy, as a rule of thumb, if they're on oral bisphosphonates, I'm comfortable. But if they're on IV bisphosphonates or they've had strong doses for cancer treatment or for multiple myeloma, then that is the kind of case that you would be better off referring. Okay, because these are all systemic risk factors that are affecting the bone of the patient, the healing of the patient, the immune system of the patient, right? We're doing surgery, we're raising flaps, there's bleeding, there's foreign bodies being placed inside. So all these general medical risk factors point back to healing, bone healing, soft tissue healing. You've got hyper and hypothyroidism. So again, if I find a problem, I will refer to the GP, try to get that managed first before I go ahead with implant surgery. Long-term corticosteroid treatment, so you've got some asthma patients on this, some arthritis patients on this. Unfinished cranial growth, so if they're really young, say less than 20, then you might suggest referring for an auto transplant or maybe perhaps socket preservation and a resin bonded bridge for now until they finish their cranial growth. Okay, we'll touch on this at the end of the lecture as well. Pregnancy, mainly because this is elective surgery and you need to take x-rays while you're doing implants. So if your patient is pregnant, I would wait till after. Certainly consider perhaps doing a ridge preservation, grafting the site so you can preserve the bone for after pregnancy, after the birth of the child, then that's a good time to place. But at least you have a management plan. Even if you have to extract the tooth, please consider ridge preservation, and then that will make the site much more favorable for a simple, in the SA, simple advanced complication classification implant placement. Immunosuppressed patients, a lot of HIV patients are well controlled. They're no longer immunosuppressed. So that's quite broad as well. Like, for example, if they have cancer, then not a great idea to be placing implants in these patients. Chemotherapy, history of chemotherapy is okay, but you've got to be careful with patients currently on chemotherapy, again, because they're immunosuppressed. And bruxism is a huge risk factor, just like smoking. They're very common risk factors. So if you have a patient that presents to you that's a smoker, is diabetic, and has bruxism, it all adds up to your risk factors. So you really have to think carefully if you select this patient for having implant treatment. Okay, so in these cases, you might consider a denture, 3-unit bridge, or a resin bonded bridge. So these are the things you have to consider if there's medical or dental risks. The golden rules for your case selection in terms of the anatomical factors are making sure you've got sufficient width of bone, making sure you have sufficient interocclusal distance. So, for example, if your 1/6 is a vital tooth that's over erupted because the 4/6 is missing, then you've really got to think twice before you place the implant. You've got to check that the implant's gone in, but then there's no room to place the crown. 6 millimeters, that you have sufficient interocclusal distance for your prosthetic. There's also a minimal vertical opening space, so it's very difficult if the patient's mouth opening is very small. There are shorter drills, but then it is difficult, so you also have to check that. And please be aware of any other pathologies such as caries, periapical infections of other teeth, TMD, oral mucosal lesions. All of these should be treated first prior to implant placement. So very commonly also is periodontal disease. So probing depths more than 5 millimeters, bleeding on probing, and plaque scores of more than 20% of the teeth having plaque. These kind of patients, you've actually got to either treat yourself with supportive periodontal therapy or send to your friendly periodontist. So they have to be managed prior to placing an implant. Your implant is basically the icing on the cake at the end of the treatment plan. Okay, so caries has to be managed, your oral health, oral hygiene, motivation, and the stability of the periodontal condition is really, really important before we start. So let's assume we've got a healthy patient, perfect oral hygiene, or even if they've had a history of periodontal disease, you've either sent them to a periodontist or you managed it yourself, and you've deemed that the patient is now stable. So what do we do next? 3 things, basically. You're looking at the restorative planning, which I've mentioned in terms of your prosthetics, surgical planning, okay, and then your basically condition of your remaining teeth, vital structures, nerves, canals, foramina, you have to look at that, and then your inflammatory lesions as well. So, for example, in this case, I've got a 2/5 that was referred to me to place. However, I noticed that there was a periapical lesion on the 2/4. So, in this kind of scenario, I would tell the dentist, well, we're not ready for implant placement in this site because you've obviously missed a canal, I'm sorry to tell you, and the buccal canal of the 2/4 has been missed. There's a periapical lesion, and that needs to be solved before I place an implant. Okay, so that's again, harping on the same topic, please look at your teeth either side, periapicals, OPGs, all of these. So panoramic radiographs provide an overview of your anatomical anomalies, pathology. For example, if you don't have an OPG, you wouldn't know this patient actually has a plate in the 3-6 area. Okay. Overall status of the teeth, bone levels, supporting levels. I've seen, impacted wisdom teeth, third molar teeth with infections for an implant patient. So all these things have to be cleaned up, sorted out before we start implant treatment. All right. Then periapical film. I can't stress how important a periapical film is for part of your treatment planning. So you're looking at the mesial-distal width. You're also looking at caries. You're also looking at your sinus. You're also looking at any pathology in adjacent teeth. So the bone quality you can somewhat assess. Definitely better on a PA than a CBCT, a cone beam CT scan. You can also check for divergent roots. For example, your premolars, sometimes the apex is tipped a little bit distally. So all these little details you will pick up from not just an OPG and a CBCT, but also your periapical film. So these 3 things is what you need. The next thing you need are study models. Now, that could be manual or digital. The reason you need study models is we need to assess the occlusion, the available space, create a diagnostic wax up, which is basically a tooth that we predict is going to fit in that site, mesiodistally, buccal width, and then you have to decide how wide you're going to have the tooth. You're going to decide, where the position is for the tooth for the occlusion. So you need basically a wax up so you know where to place the implant, because we actually do prosthetic driven design. So you can see from remember the first few slides, you remember the crown had a hole in the middle. It's in the middle because we placed the implant in the middle, but how we got that there was because we actually did a diagnostic wax up of what shape and size and position that premolar was going to be. So then we know where the center of that crown will be for placement. Okay, so you actually work backwards. You're going to visualize what the tooth looks like and then go work backwards to place where the implant is so that it's always centered. If anterior teeth, so remember the case that I just showed you for the 2-1, then the screw access channel is on the cingulum. So you want to hide that screw access channel. So from the diagnostic wax up, we create an X-ray template, and then we also use this for patient communication. So old-fashioned would be manual impressions. So this is an impression of, I think his name is Anthony, for C3PO. Okay. So when I did my graduate diploma, and my mentors were Richard Chan and Vincent Liu, we did manual wax ups. So this is a 3637 case that I manually wax up. We took impressions, we did study models. Impressions were manual, okay? But now it's mainly digital, okay? We go from the consultation stage, which I'll run you through, the examination stage, which you now remember. It's the OPG, the CBCT, your study models, diagnostic wax ups, and your PAs, don't forget. Also your probing, so please do a periodontal probing record. Make sure you have a good record of their bone levels, probing, and plaque, okay? Take some photos, of course, and then make your models. If you want to go digital, then digitize your models, or if you've got a scanner, then your models are already digitized. What we do is we actually merge the CBCT data, which is the bone scan, to the STL file. STL is standard triangle language. It's basically your digital study model. So you merge the digital study model with your bone scan, and that's how you work with that data to plan the implant. Don't forget the restorative driven planning I've told you about. We design the surgical guide, we print the guide, then we go to surgery, and then we restore. So that's the workflow. Again, going back to old school, basically we used to use like pen and paper, stickers, and a stencil. So you would have a one-to-one stencil, and you'd have a printout of the scan, the CBCT, and then you just put the stencil manually onto this 2D X-ray, and then just choose a size, a length, and a shape of the implant that fit. So you can see from this CBCT 3D scan, which is the one that I showed you that I waxed up, the 3.6 and the 3.7 sites have been waxed up. So you can see here, there's your 3.6, there's your 3.7. Okay, so we've waxed those up. We drop a line, we read that it's slice 150. So then we slice 135, 158. So we know that that slice is for the 3.6 implant site, and that slice is for the 3.7 implant site. So it actually is good to get your radiologist to just print you out manual copies so that you can actually use manual guided surgery just to get your head around planning. So you can see that's my restoration, middle of the restoration, drop down, and this is the slice that we're looking at. So we're looking at here the soft tissue that's highlighted by barium sulfate. We're looking at the crown, the diagnostic wax up that we plan, and then we're looking at the bone, the volume, we're looking at the width, and we're looking at the length. All right, so these are the things that we are doing at the treatment planning stage. Okay, so this is an example of a plan. We're measuring the width, we're measuring the length, and we're measuring the distance from vital structures that could be sinus or that could be inferior alveolar nerve in this case. Okay. Important things to note about CBCT scans. You do have to learn how to treat the data or prepare the data. So you've got to segment, which means move the data into a upper and lower maxilla. So you isolate them so that you can manipulate the data. Okay. Then you've got you draw your panoramic curve. So if your panoramic curve is wrong, then your slices, so remember those slices that I told you? Those slices are perpendicular, right? But only properly perpendicular if your panoramic curve is exactly along this line. So you want your perpendicular slice to be exactly along the mesiodistal line of the tooth, like so, like so, like so, like so. Okay, so if your panoramic curve is a little bit out, then that means your perpendicular line will be off. So then you would think that you've got more bone than you really have. Okay, so this is very, very, very important tip. A basic tip is to make sure that the panoramic curve plotting is spot on, because then that will influence the way that your slices look when you're measuring your implant bone volume. Okay, so the next thing is you either take in a manual impression or you do a digital scan, and you're aligning this with your CBCT, your 3D scan. Okay, so once you've aligned, right, you've got then a model in virtual reality, which you can then do diagnostic wax ups and plan your implants. Okay. All right, so a little bit more about planning. So there's some anterior cases. So again, highlighting that everything we do in implant dentistry is restorative driven. So this is ExoCAD, where it's a program that labs use to design the crowns first, and then from the design of the crown on your study model, okay, then we decide where to place the implant. Okay, so in the anterior, very important is we want the screw access channel, which is basically the line where the tooth is coming out or where the implant direction is, has to be on the cingulum side. So if you're a beginner, I would definitely suggest to avoid any anterior implants at the beginning because they're very tricky. You know, premolars, molars, great. Anteriors is advanced because a few millimeters off or few degrees off, and you could end up in a implant position that's, for example, coming out the incisal edge, for example, here. Okay, and so if this a few degrees off and your implant is coming out on the incisal edge, then restoration is difficult. You might have to cement or glue the implant onto the implant crown onto your implant, and that's difficult because then it's not retrievable. You can't take that off if there's any complications or anything you have to fix with the implant. Okay, so this is the same case. We've got your diagnostic wax up, okay, and then we've got the CBCT scan. So remember, we're merging the bone scan and the 3D scan of your mouth merged, okay, and then we join the dots. Basically, we join where are we going to place the implant so that the screw channel is going to be where we want it to be. Okay, that's it in a nutshell. And so that's the case finished. Okay. And that's what that case looks like in real life. So he's got periodontal disease, but very stable. And this case was Dr. Janice Lau, okay, restorative dentist. Okay, check for pathology. Again, harping on the same thing. Lots of cases that I see have periapical radio opacities on adjacent teeth. So you can see on the 6 here, and then you can see on the 5 here. So again, basically treatment planning, basic treatment planning. Okay. In a sinus area, you've got a pathology, but also in this case, not only you have pathology, but you've also got a tooth with furcation involvement here, bone loss, periodontal disease, and very thin bone here. Okay, so we look at our implant shape and size. So we would need to manage this sinus issue, pathology, as well as create more bone. So this is a complex case. Okay, not for a beginner. All right, so pathology. And this one is an impacted 8, I think it is, on a patient that we're planning an implant. So basically, again, patient's not suitable yet, manage the impacted 8 with the cyst first before implant goes in. Okay, that's the case there. So it's quite a big pathology with a cyst around the impacted 2/8. Implant case was the 1/6. Okay, one last word of warning is that, and this slide's from Professor Richard Chan, do not trust anyone but yourself when it comes to reading CBCT scans, plotting the nerve, and planning. In this case, the radiologist has plotted the nerve like this, and it goes down like this. But in actual fact, that was not the real plot. If you look closer, the nerve is here, here, here. Okay, so this case, unfortunately, ended up with a complication because the dentist thought and followed the pink line drawn by the radiologist, but the pink line was wrong. Okay, so this is a terrible, terrible implant complication because the patient is basically numb forever. Okay, and it's iatrogenic, caused by the dentist. And this is a very good dentist, so it can happen to anyone. Okay, so never trust anyone but yourself. So we're going to move on now to implant treatment protocols. So that is about the timing of implant placement. So when a patient presents to you, you've already decided that the tooth cannot be restored. Okay, you've either extracted the tooth or it's already extracted, it's missing. Okay, then you've got to decide from extraction to implant placement, which protocol are you going to use? So you can do type 1 protocol, which means you take the tooth out and you place the implant straight away. Okay, this is very highly technique sensitive, as you can see from the picture. You've got a socket, a molar socket at that, and then you've got this tiny little bit of interseptal bone, which then the implant's placed, but then you've got to manage the socket. So you've got to graft everything around it, and then you've got to somehow seal this off so that bacteria doesn't get into the graft. So it's not an easy feat to do type 1 placement, and it's not my favorite. I hardly do it. Okay. Type 2 is my general day-to-day, basically. It's 4 to 8 weeks. So from extraction of the tooth to implant placement, I tell my patients to come back around 2 months. Okay, so your soft tissue has healed. Your bone has not completely healed, but that's fine. That's not an issue. It doesn't have to be completely healed for you to be placing. So it's not fully matured. And you might have to graft. So, for example, in this case, we've got soft tissue healing. So that tissue was all the way out here. So 4 to 8 weeks. However, you've got a little bit of dehiscence. So basically, there's bone missing on the buccal of that implant. So that's grafted at the time of implant placement. So in this scenario, the patient comes once for the extraction and once for the implant placement, and bone graft is added around that implant at the same time, so one surgery. I then see the patient a week after that to take stitches out, and then I then see the patient 2 weeks after that, 2 months after that for restoration. Okay. Type 3 is 12 to 16 weeks, and then type 4 is more than 16 weeks implant placement in a fully healed ridge. The downside of fully healed ridge is that after 4 months, you'll see a notable reduction in the width of the bone. So, for example, at the time of extraction, you had 8 millimeters of bone. Okay, that actually will atrophy, it will resorb. So, if you come back to that same patient 6 months later, right, you'll only have 4 millimeters of bone. And how big are our implants? They're 4 millimeters wide. And how much bone do you need around the implant for the bone to be vital and for bone to actually osseo-integrate, which means biologically attached to the implant? We need 1.5 millimeters. So we actually need 6 millimeters of bone width to be able to place a 4 millimeter implant. So I would advise against waiting 6 months for placing an implant, because your bone, generally speaking, is not there. You've lost width. Sometimes in an upper molar sinus site, you've lost height. So then you've complicated the surgery because you need to do sinus lifts or grafting and so forth. The exception of this rule is if you decide to do ridge preservation. So when you extract the tooth, you've decided to put bone graft in to the socket, then you basically hold the bone volume and you can choose between type 2, type 3, or type 4 in those patients, because you've actually preserved the width and the height of bone for a choice of implant placement treatment protocols. Okay, but general rule of thumb is extraction of tooth 2 months, implant placement 2 months, and then restoration. You can do 3, 3, and 3 as well. So extraction 3 months and then restoration 3 months. What I explain to my patients is also they have a choice of submerged or not submerged implants. So again, going back to basics, we've got our implant, which is here, into the bone. At the beginning, these screws actually grip onto the bone. So you have what's called mechanical stability. It's literally the wings or the threads of the implant cutting into the bone. There's a little bit of compression, so the implant actually stays stable, no mobility, because of the mechanical stability. Okay, so that's the implant. The tissue level goes up a little bit higher, and this is your abutment. Okay, this is called the healing abutment. We place it for the soft tissue to heal around. So this, in a bone level implant, is the implant, and then you've got your healing abutment, and then again the soft tissue goes around that. Okay, so you can have different kind of healing components to if you want your implant to be completely submerged so that the skin completely covers the implant. And you can do this for patients that maybe don't have such good oral hygiene, or if, for example, you're a bit worried about them wearing a denture over the top or loading it. Okay. Generally speaking, patients in the literature and in terms of papers asking patients about their preferences prefer straightforward implant surgery over complex implant surgery. So that means if you can preserve or ridge preserve the site so the implant is straightforward, they prefer it than if you left the bone for 6 months and then the bone's collapsed, and then you've got to do all sorts of grafting to build the bone back for the implant placement. Okay, and the same, this is what bone graft looks like. It's made of bovine bone, so it's cow bone. And this is what soft tissue looks like if you basically take some keratinized tissue or soft tissue from a donor site and use that for grafting. Okay, so generally speaking, patients like simple. So just keep that in mind for your treatment planning. Okay, keep it simple. If you had a site where the nerve, and now you know what the nerve looks like, is very close, right? Then patients prefer shorter implants, okay? So that they don't go through big grafting procedures to build vertical height to be able to place an implant in, okay? And this is the kind of grafting that you do to build bone height, and it's not an easy feat with block grafts and so forth. Okay, so short implants, straightforward, patients prefer. Patients also prefer less surgical intervention, so that means choosing narrow implants versus wider implants. Okay, and this is an overdenture case where we use implants to support a denture. Okay. And in terms of the upper molar areas, you can see here there's a sinus. So this is a sinus. Yeah, this is a sinus. So above this is air, basically, connected to your nose. And below this white line is your alveolus or bone. Okay, so both of these sites are not there's not enough vertical height for implant placement. So in these cases, you can choose short implants or sinus lifts procedures, which is again not for beginners. This is something that you would refer. So these are the things you're looking for in terms of treatment planning. Okay. If we're focusing on anterior teeth or anterior implants, so these are the modalities. We can do the healed site, which is either 4 to 8 weeks, which is type 2, or type 3, or 6 months or more, which is type 4. But sometimes you don't have so much bone in type 4, so don't forget that. This is the grafted type of placement, and this is the graft that we place around to build that bone back up around the implant. And then this is a block graft. So patients don't like this. This is there's a lot of surgical morbidity. They get this bone from the chin, and then there are patients where the lower anterior teeth lose the vitality, and also there are patients where the chin goes numb just to get this block graft from the chin to place. So again, try and keep your cases simple. Okay. Talking about immediate implants, so you can section a tooth in a way where you then place the implant at the same time as extraction. That was type 1, remember, placement. But then you have to manage the socket around, okay? And then you've got to manage the soft tissues around that as well, okay? When we ask patients about the study, basically there's patient satisfaction between immediate implants and regular implants are the same, okay? So you can pretty much feel comfortable just telling the patient, let's wait 2 months after the extraction and then we'll look at placing an implant. Let's wait 2 months after placing the implants and then we'll look at restoring the implant, okay? So in terms of failure rates, the immediate implants have higher failure rates. Obviously, some patients will feel happier if you restore immediately. So that means you place the implant and instead of waiting 2 months to put your crown on, you just go straight away, okay? However, there is a risk because you're loading the implant. And remember how we talked about how the implant has to have stability. So if you have loading, there's some stability problems, then your implant will fail. Implant failure rate overall is about 2%. But if you're going to be doing immediate implants, if you're going to be doing grafting, if you're going to be doing loading, which means putting the crown on earlier than the time that the implant has integrated, then you're changing the risk pattern, so slightly higher risk. Okay. So again, please don't wait too long. So this is a case that I want to show you where the extraction has been done, patient has been told, wait 6 months, come back and see me, or wait 6 months and then go to your surgeon for an implant. You know, that makes it complicated. We've got an incisive canal here. We've got very, very thin bone here. And remember, we need, even though we use a narrow implant, we need 1.5 millimeters of bone either way. Okay. And then when we place the implant, we call it dehiscence, means the implant is showing, and then we have to graft it. Okay. So please keep in mind, tell your patients at the time of extraction, the best timing for the implant is 2 or 3 months after the extraction. If they're not sure, then do this. This is ridge preservation. So you take the tooth out. On the same day as you're taking the tooth out, you feel bone, cow bone, bovine bone, or porcine bone, or if they're vegetarian, you can use something like ethos, which is calcium sulfate. Place that into the socket, cover it with membrane, wait, and you'll get soft tissue healing, bone healing, and that patient will keep the bone volume because the bone graft is a space filler, space maintainer. So you keep width and you keep height by preserving the ridge. Okay, so you basically stop helping the body to preserve the width, both bucco-palatal width as well as vertical width, to prevent that atrophy. So in that case, it makes your implant placement more simple. Okay, so remember, simple, advanced, complex. Remember, our patients prefer simple treatment rather than complex treatment. So this is the best way that you can help your patients keep their treatment planning simple. And remember, with this technique, you can place an implant at type 2, which is 4 weeks or 8 weeks, or you can do type 3, which is 12 onwards, or you can do type 4, which is like even longer than that. Okay, so this is another case where the anterior tooth is irrational to treat. She's had a post-core crown for many years. It's fractured. We graft. This is porcine bone. We cover that with this is called mucograft, so it's like a collagen substitute from a pig source, porcine source, and then we wait. Say this was probably 4 months or so, and you can see that the bone width is fantastic. So remember what this looks like compared to the other case we showed you. Okay, and that's the width we have around the implant. Okay, so treatment planning wise, it's very important to have these conversations with your patients at the time of extraction and explain to them the importance of timing. It's so important. If the patient's undecided and they wait 6 months, you end up with a very complex case. If the patient's undecided and you do a ridge preservation, the patient can come back in 2 years and the bone often is still there for you to place as a simple implant placement. Okay. So this is another case where the dentist told the patient to wait 6 months to come back, and then they referred to me. And so in this case, I could either do a block graft or a bone graft, which we did, and then that's quite involved for the patient, cost-wise as well, and also morbidity-wise, because they had to have multiple surgeries. So how to have the initial implant consultation conversation with your patient, okay? What dentists are interested in are bone levels, primary stability, types of implant screws, types of fittings, 1 or 2 stage surgery. We're very into the nitty gritty of the actual mechanics or techniques of surgery. But what are patients interested in? They're not interested in you showing them a bunch of screws, okay? They're actually interested in you describing for them what is it going to feel like for them to have an implant. Okay, what are the options available to them, and what are the outcomes that they're expecting? So these are the things that you have to explain to them at the implant consultation. So they're concerned about what is the effort required for treatment? Is it going to be painful? Do you need sedation? I'm going to have time off work. So yes to everything, right? Some patients prefer sedation. Some patients are fine with just local anesthetic. Generally speaking, you need 2-3 days off work if it's one implant, maybe just 1 day. But if it's multiple implants, then they need 3-4 days. So similar to dental extraction kind of timing. They want to know the effort required for maintenance. So what's required for them to maintain an implant? And we're expecting patients to keep implants for 10, 15 years. So we need to tell them what to look out for in terms of complications and how to clean them. Okay. Um, pain free. So obviously they want surgery to be pain free, but also afterwards the implant to be pain free. Okay. Their priorities when they come to you for a dental implant is often function. They want the tooth back because they can't eat certain things such as chips or steak or hard foods, or sometimes people just can't eat salad, okay, without the certain tooth. Aesthetics, so that's obviously more for the front teeth. Pain, they might be having pain from their dentures, or they feel uncomfortable with eating with a missing tooth. Okay, so overall, their quality of life is suffering from the missing tooth. Okay, you do have to ask a basic question of the patient when they've lost a tooth: is do you feel you need the tooth? Okay, it's a very basic question, because often some patients don't need the tooth. Okay, their quality life hasn't suffered. They're doing fine without the tooth, especially like a 1-7 or a 4-7, or even if it's a 1-6, but they still have enough teeth on the other side, then they feel they don't need the implant. And that's perfectly okay, because if you then go ahead and do this elective surgery and then the complications, it's going to bite you in the bum when then they say, oh, well, all these complications, but I didn't really need the implant. So why do we do it? Oh, just because the doctor said to do it. Okay. So very important to have a conversation. Does your patient need an implant? What do they need it for? And then document that, okay? Because then you know the patient's motivation for seeking treatment. And this treatment's elective, and it's not inexpensive. We're looking at about $6,000 on average for a replacement of a tooth, okay? So it's a significant investment. Patients are also interested in confidence, function, speech, eating, and then if they're in a denture, they want their denture to be more comfortable, not fall out or be embarrassed when the teeth are moving, or be able to have the confidence to eat in public. Okay. So often patients are bamboozled, so they don't know how to decide when you give them the options of root canal treatment or implant, which you give them the options of a 3-unit bridge or an implant. It's very, very difficult for patients to decide. Sometimes they've decided, but they just want confirmation from you to know that they've decided the right thing. And then sometimes they just think you know better, so you decide for me because you're the doctor. Okay. Now, with great power comes great responsibility. You have the power, but then also that is a big responsibility if you're making a decision based on what you feel about whether that patient needs an implant or not, or whether the patient should have, for example, a sinus lift or some complex surgery to replace a tooth, or perhaps should they root canal treat the tooth, or and keep it, or take the tooth out and place an implant. Okay. So again, it harps on that question, Doc, what would you do if you were me? So in this study, a group of dentists were asked a question. So if your patient asks you, Doc, what would you do if you were me? What do these dentists reply? So 58% reply that they would answer as if they were choosing for myself. So for example, an upper 6, irreversible pulpitis, I would personally extract the tooth and replace it with an implant. Okay. 19% decline to answer. 6% will answer based on the evidence, based on the average patient. So you can say 70% of root canal treatments are successful, but 30% fail. So for example, in your case, perhaps you could extract the tooth and replace an implant. So they're citing literature to give advice to that patient. Only 17% will answer if they were the patient in front of me. That means these clinicians have taken the time to ask the patient what is important to them. Some patients say they're 45 years old, and what's important to them is they want to keep their teeth in function for as long as possible. That kind of patient, I would definitely, in their shoes, would prefer to root canal treat the tooth, place a crown, so that they're 55 or 65 before they lose the tooth. And then at that point, we would place an implant for them. Does that make sense? But if it was like a 70-year-old and the tooth was root canaled already, it's up for second time root canal treatment, then it's kind of justified. Let's remove the tooth. Let's not go for a second root canal. Let's replace it with an implant. So you do have to understand your patient. Why did they want the implant? What angle are they coming from? Are they coming from function, aesthetics? Do they want to feel confident? Is comfort is important? Or aesthetics important, function is important, phonetics important. Maybe they can't go one day without an implant because they're on TV, or I've had an opera singer. Okay, so then we might go for an immediate implant with immediate loading. So our treatment plan changes because of what the patients are like. Okay, so the conversations between patients and dentists is pretty much like an average marriage. Okay, so the dentist thinks that this is the best for you, but really the point there is put yourself in the position of the patient. Try and learn and understand your patient and ask them what are their values. What are they looking for? What outcome are they looking for? And then help them decide together as a shared decision. Should we extract the tooth? Should we replace it with an implant? And what kind of scenario are we going to treatment plan? All right. Final section is when to refer and when to treat. Okay, so these kind of implants cases is similar to what I was saying before. Tooth was extracted, and that we've lost bone width, bone height. So when we place, there's a dehiscence, which then has to be grafted. So this is advanced. Okay, this can be avoided if we manage the socket with bone grafting at the time of extraction, or if the patient had better bone volume and we place the implant in a timely fashion. So in these instances, then I would suggest that you refer. So if you do have access to a CBCT, you can take a CBCT when the tooth you're about to extract is still in situ, and then you can actually have a look at the bone volume around that tooth. So remember, you need enough bone for the implant, and generally speaking, that's 1.5 millimeters preferable. 1 millimeter is okay, but not great. Okay, so you can see in this site, this particular patient, this is too thin for an implant. Okay, this is only 2.3 millimeters. Okay, smallest implant on the market is like 2.9 millimeters. Okay, bone defects. So you're looking for alveolus shapes. So these are all difficult cases, and probably best to refer because they're anterior cases. Very thin bone here. In this case, you've got caries. The tooth needs to go, but then you've got the nerve there. So once you've taken that tooth out, there's very little height there. So this is definitely a ridge preservation case. And these kind of cases are sinus lift cases. So again, it's kind of case that you would refer. Unfinished cranial growth. I talked about this in the beginning. Okay, so this is a case where the lady had a tooth implanted in her 20s or 30s, and she's now in her 60s. So I wanted to highlight these kind of cases. The what happens is that the implant stays in the same place, right? But then your face grows, right? Your face elongates, it grows downwards and forwards. The implant's left behind. Okay, so then you have this incisal edge discrepancy. So please, if you have a young patient, that's again, please refer because we do manage it differently. Young means under 23 in an anterior site. We might be looking at autotransplantation. We might be doing a ridge preservation and then a resin bonded bridge first to tie them over until their facial growth is completed, which is around 24, 25, 26. The older, the better, basically. Okay. So please consider young patients because this is what happens. Very, very difficult anatomical sites. So like lower anterior teeth, again, I would suggest that you don't try this at the beginning. Very challenging. Also remember, we have to get it lingual access. So you have very little error in terms of angle to get the implant in the right position. Okay. Full arch cases. So these are advanced.
So this is a lady where we've placed implants and given her fixed dentures. And then this is a lady that we've decided that she just needs function. She's quite happy to remove her denture, to wash it and put it back in. So in terms of asking the patient what she wants something that's cost effective, easy to clean, good hygiene. So this is called an implant overdenture. So basically, it's 4 clips on those locators, which are those black buttons. They clip on. So she's got her aesthetics, she's got her function, and then she's also got her confidence in eating out and so forth. So this is another case, type of case that you could refer. Complications, infection. So implants can fail from infection, often if there's not good primary stability at the time of placement. Tissue dehiscence. So this is basically loss of tissue around here, and then you'll also get loss of bone around there, so complications as well. And then bleeding and hematomas. So if you do implant surgery, you need to understand risks, which we said talked about at the beginning of the lecture, and complications, and be able to manage them. Okay, so summary of treatment concepts. Basically, you've decided the tooth either is irrational to treat or the tooth is missing already. Okay, you've talked to the patient about the options: a denture, a traditional 3-unit bridge, which we don't like to do because of the biological cost of having to shave the teeth on either side, or an implant. Then we place an implant. We have to decide, is implant insertion within 2 months possible? So, for example, if there's infection, periapical lesion, then that alters our decision making. Okay, so then if it is not possible, then we graft. So that would be ridge preservation that I talked about, putting bone in, building it up, managing the ridge. And then if it is possible, then we wait 2 months, we place, and then at placement, if necessary, then we graft at the same time, which is I would suggest that's an advanced technique. Okay. And that's the end of my presentation. It's very hard to give you a summary of implants in an hour. The list that James gave me was very long, so this is about a whole day lecture, distilled. Actually, it's 3-day lectures, and I'm also Richard, myself, Dale, and Lydia running a 3-day implant. It's fully subscribed for May, but we're doing it once a year, every year, run by Association of Australian Association of Implants, so AOS, Osteogradation Society, which I'm the president, as well as ADA. So look out for courses that I think James also is GDR, so you've got a course there as well. You need more than 1 hours to go and place and restore implants. I'm just trying to give you an overview, but it's a lifetime of learning. I've learnt implants for, I I would say it's like now 12, 13 years now, and I'm still learning. You start with restoration, then you go to surgery, the simple cases, then you go to advanced, and then you go to full arch. So you never stop learning. And then there's complications, and you're going to manage them, and then you're going to try and work out, why did I have that complication? Did I pick the patient wrong? It's like the risk factors, I missed something. Okay, so all of these things are part of being an implantologist. So I hope you all enjoy your implantology journey, and wish you all the best. Definitely reach out to James or I for further information and education. And thank you for being us tonight.
Thank you so much, Cecilia.
You're welcome.
Cecilia, we have a lot of questions to go through in another moment.
Oh, sure, sure, sure.
I think there are some overlap as well. So if you've got a
Go
moment,
for it. I've got all night. Go for it.
we
What
got
would
all
you
night.
like
We
to
got all
know?
night. And to everyone who's, I guess, starting their implant journey, Cecilia is correct in that the implant learning is always evolving. The literature is always evolving. And the learning is always ongoing. I know
It's
myself. I've almost spent almost 100K on implant learning, and I'm still going to do more
It's
courses. So,
yeah.
um, it's not
Even
just 1
my
hour lecture and you're
mentors
done.
still, yeah, my mentors are still attending courses. So, and they're in their there's ones in their 60s. He's
Yeah,
doing soft tissue
it's
courses. So
endless.
it's forever. So if you're bored of dentistry, right? Like general dentistry is boring for you. This is it basically.
This
It's
is a
like
great
so
like
much,
place to burn your
so
money. Yeah,
much, yeah, CPD, and it's like surgery, aesthetics, restorative, everything. So you'll never get bored, basically.
you won't. No,
Yeah,
there's so many aspects to it.
correct.
Okay, let's get to the questions.
Sure.
Let's see. Okay, we've got Rebecca here. What program do you use to plan your implants?
And
I
my
think you
implant.
showed some screenshots,
Yeah.
but what?
If you want a free program, then go Implant Station. If you're buying implants from a particular company, then you'll end up having a bundle, right? So the program I use is Co-Diagnostics because I use Straumann implants. But if you use like Nobel, then you'd be using DTX. So generally speaking, you use the say Zimmer would be Real Guide. So you use the program that comes with the implant because it's a bundle. So, but if you want free, go Implant Station, and it's a really good program. It's free, so they just charge you when you want to export a file to print a surgical guide, and it's not expensive either. Yeah.
Yeah,
So I'd go Implant Station if I
yeah,
was you.
implant
Yeah.
station, and I use
Blue Sky
Blue Sky
Bio, I find a
Bio.
little bit clunky.
Yeah,
Yeah.
pros and
So
cons. Yeah,
yeah, yeah.
what do
So
we
for a
like?
learner, it's like a little bit clunky, is difficult. It's like Android versus Apple. You
It
want
really is.
something
Yeah,
like
implant
yeah,
station is very a bit more simple to use.
yeah,
Yeah,
yeah.
it's a nice
Yeah,
on
you
ramping
want
one.
simple.
Next question. What are your thoughts on restoring site 3646 if it's the last standing in the arch for
No problem.
beginner?
Yeah, so I mean, 3646 is a really good site to start off with, like surgically and restoratively. Um, you do have to have a good maintenance plan. So it's not just issuing the crown and go bye bye and that's it, right? You're seeing the patient every 6 months. You actually got to check for the contact. So you might get what's called a mesial gap. So your premolars, especially uppers, less so lowers, the fives creep forwards, and then you get this tiny little mesial gap between the distal of the five and the anterior of your six. Okay, so second is check the occlusion, not just at the time of issue, but every time you see the patient, because the occlusion changes. And if it's a 3646 in particular, and the last standing tooth, then the main point is the occlusion. Okay, you've got to really, every time the patient comes in, check that they haven't got excursive contacts and there's still light contact on clench, because the implant doesn't have a periodontal ligament, whereas your tooth does. So if you're clenching, and this is why bruxes are a problem, if you're clenching, all your teeth kind of sink in a little bit, and then your implant's proud. And at some point, you chip porcelain, your screw comes loose, you damage the screws, like all sorts of mechanical and technical complications come from that. Simple is check the occlusion and adjust the occlusion over time. And that's pretty much it for anything, not just the last standing 3646, is that continued maintenance of checking your occlusion, probing depths, your soft tissue, um, like that. So I think 100% go ahead, but check the occlusion, you know, every 6 months or every year.
Yeah, agreed.
And you have to have
Next,
shim stock. So make sure when you bite together, the shim stock comes out. That's really
so
important.
shim stop guys, it's like silver paper.
Yeah,
You want
the
to be able
kind
to
of
pull
looks like
through.
silvery. Yeah, that's right. Yeah. So you want to have freedom of shim stock. There's all these different shim stock grades. So yes, you can go to town with shim stock. What is the general minimum age we should consider implant placement in men and women? I would say as old as possible. In women, they say maybe 23, 24. more. It's still, yeah, something like that. In men, I think it's a little bit older, so it's 24 more. Yeah. It's hard because I have 19-year-olds coming to say, I'm 19 now. I've been told that I've had missing laterals my whole life. I've been wearing Distentia, and on my 19th birthday, I can have implants. And I'm like, oh no. So they've been promised this and they've been waiting and they just want it at age 19. So certain things that we do, we talk to the patient and show them that picture about the incisal edge, show them the consequence of facial movement, which means that the implant would be longer. I'd sometimes place the implant deliberately lower because I know that it's going to end up higher. And then I tell the patient that I'm going to have to change your crown in like 10 years time, or maybe 15 years time, it's going to change. So if they understand the risks, then yes. A lot of them look at the picture and then they go, oh, okay, I'll wait till my 21st birthday. And I'm like, so you try to convince them to push it to 21, 22. I'm much happier at 23, 24. But even then, you expect that your gingival margin will change and your incisal edges will be off at 23, 24. Yeah.
Yeah, it's a very
Yeah.
debatable question, very
Yeah.
controversial.
Yeah.
Yeah,
So
I
if you
even heard the
can
other
save
day
the tooth,
people trying to push 30-year-old like
30 is
over
way
30,
better.
but
I'd be,
yeah,
heaps happier. So if you
which is
can do a root burial,
but yeah, I think I
so
agree. Like as long as you give
yeah,
those risks to the
yeah,
patient.
talk to them about the risks. And some patients are like, oh, I want it to be perfect forever. Okay. And they're 23. Then I'd say, why can't we do a root burial? So you bury the root, right? So if there's something wrong with the tooth, but it's not irreversible pulpitis, it's still vital. Say, for example, they had a trauma or something, but it's the root you can bury, right? Then you can actually do a resin bonded bridge over a buried root. Okay, or you can do an auto transplant, or you could do ridge preservation. So there's lots of options to delay the implant placement. You can definitely manage it in different ways. Do you think 4 to 8 millimeters in a molar site is okay? What is the minimum diameter you would place? So it depends on your implant brand. So if you have a implant brand that's slightly softer titanium, I would say no. So I would say minimum 4.3, 4.4, 4.5 in width for a molar. 8 I'm happy with. Like most of my implants are 8. All right. It's the width. And also when you come to restoring a molar, right? Molar is this big and then your implant is this tiny. You end up with like how to describe it? Like if that's your implant and that's your tooth, you have a huge ridge lap. Yeah. So then you have to sink your implant lower to be able to get the emergence profile. So from there to there, you need more room. Does that make sense? So if you've got a narrower implant and then you've got a huge crown, you've got to get from there to there. So you need more space to get from there to there. So a 4 millimeter implant in a molar site, you have to place deeper. Yeah, to be able to get that shape up. Otherwise, you end up with a tabletop, like straight across and ridge lap 90 degrees out.
Yeah,
And
almost
then
like a lollipop.
and that's going to be a complication because you've got a right angle, right, from the implant to the base of the crown. You've got plaque, and then you have periimplantitis, and you'll end up with complications. So 4 by 8 is okay if it's an implant brand that has an alloy. I would then have to place it deeper, which makes the restoration more difficult. I would generally go for 4.5. Yep. By 8 is fine. 4.1, it's okay. Not preferable, but okay, you can. You have to manage it. Yeah.
Yeah, I'm
Yeah.
in agreement with that.
Yeah.
Yeah.
Yeah. In type 2, would you still expect 35 Newton centimeters primary? Yeah, I still get 35 Newton centimeters primary stability. Maybe not in the maxilla, like posterior maxilla, but generally everywhere else, yes. You know, the 35 Newton centimeters primary stability is dependent also on your drilling protocol. So if you have soft bone and you're drilling to length for every single drill, you're going to have less primary stability. But then if you have a soft bone and you have a drilling protocol where that particular implant allows you to under prep, all right, then you can have a little bit more compression in the bone because you've prepared the hole slightly narrower, and so therefore there's more like grip, there's more compression when you put the screw in, so you can um, generate that primary stability by controlling your drilling protocol, how deep you drill and what size you finish with. Yeah, hope that makes sense, Daniel. Danica, right?
All right. Next one.
For beginners, which implant type of protocol do you think? Definitely either type 2 or type 4, 3, sorry. Maybe type 3, because sometimes I find with type 2, 4 to 8, I place and then remember that case with a little bit of dehiscence, then we have to graft. So then you might end up kind of unexpectedly having to graft. And then you're like, oh my God, I don't know how to graft. And I put the implant in and there's no bone there. And what am I going to do? Panic, panic, right? So I would say extract, do a ridge preservation. So you know that there's truckloads of bone, and then wait 4 or 5 or 6 months so that you've got, nice bone in that site, and you've preserved the ridge so that you know you're not going to be stuck in a position where you place and suddenly I can see the implant at the neck. Then what am I going to do? Ring James and fly down and fix it for me. Yeah. So I would say go slow, preserve the ridge so that you can avoid needing to do simultaneous grafting when you place the implant if you don't know. By the way, if you want to do grafting, if those people out there are not beginners, in September, you can direct message me. We're doing a cadaver course. So that's for grafting.
Amazing. Yeah, I agree as well.
And then
There's
does
nothing wrong
GDR have a grafting course as well?
as
Cadaver
part of
course?
our general residency. We have like an implant module where we do some grafting.
Yeah.
You can
Yeah.
practice
Is
the
that on a
soldering and stuff.
cadaver?
It's on pig's jaws, and so not as advanced as
Okay.
your course, Cecilia. So
No
that'd be
problem.
nice. It'd be very
Yeah.
nice to do real life on cadavers.
Yeah.
I think that'd be very valuable.
So definitely, I would say do a simple course. Do the GDR course with the pig's jaw grafting, because at least if you're stuck, you can remember what you did on the pig. All right. So it's important. You know how we said you must know the next step, how to manage a complication, right? So if you're going to place an implant, you need to know how to do a GBR, even if it's on a pig's jaw. Agree?
Exactly.
Yeah.
Exactly. Yeah.
So
You just gotta know the steps. Have it all planned out,
just in case. Yeah.
just in case.
Yeah.
All right, next one.
How long do you wait post exo that has an active infection? Still 2 months. Ooh, good question. I take a PA and then I'll have a look based on the PA. 2 months, sometimes yes, 2 months, sometimes no. What do you think, James?
I'm. It depends on how big the lesion is as well.
Yeah.
The bigger it
Yeah.
is, the more I'm willing to wait.
Yeah.
And I think it also depends on how well you've degranulated your extraction
That's
socket
true.
after you've
And
taken the
whether you
tooth out.
put something in or not, or something like that. Yeah.
Yeah, yeah.
Yeah. So
But I agree. You
maybe,
take a radiograph
yeah,
and
take
see.
a PA. Mm.
Yeah,
You can always take a radiograph in 2 months and then maybe delay it 3 or 4. Yeah.
yeah. Nothing wrong with waiting. Like,
Okay.
don't promise your patient you'll put an implant in 3 or 4 months.
Yeah.
You just promise them you'll review in 3 or 4 months or
Yeah.
take an X-ray and
How,
go from there.
James, how long is the GDR course? How many modules, or what is it, like 1 year or 2
It
years?
goes over 9 months with 5 modules, and
Oh,
one of
that's
the
pretty
modules
good.
is the extraction implant
Yeah.
module.
So they learn from implant placement through to grafting through to restoration.
Yes, yes, very. It's a
Yeah.
very well. It's a weekend course, you would say. It's just a very compressed timeline.
Yeah.
Um, we
9 months is
are
pretty good. Yeah.
yeah, it's not bad. Yeah, oh, it's not a well. It's one module on implants and one module like restorative, like general dentistry. One module on endo, one on communication, photography. Another one like cutting crowns and onlays. So
Oh,
that's our
okay.
general
So
residency.
the 9 months includes all other types of dentistry as well.
Dentistry. Yeah,
I got it.
yeah,
Yeah.
yeah.
Okay. Sign up,
I
everybody.
guess I guess I can probably just sneakily pre-announce we are working on an implant 18-month course at the moment. So just keep
I
your eyes peeled on that one.
Yeah.
So
Honestly speaking, it's 1 hour, 3 days is just not enough.
it's not
Like
enough. No, it's
18
not.
months is minimum just to get started. So
Yeah, just to get started. Yeah,
yeah. So yes. So everyone keep an eye out because I would highly suggest 18 months. Yeah.
18 months. Yeah, I
It
think
takes
after
6
my
months
first
to finish
18,
an implant case.
you can it's very hard to find the cases as well. In
Yeah.
when you take on a course, you got to find the patients as well. So you got to find the
Yeah.
extraction case and then find the graft and then convince them that
Yes.
you're going to do an implant and then
Yeah.
convince them that you're the one to trust for them to put an
Yes.
implant even though it's your first time.
Yeah. Yeah. Well, you have mentors watching you, so that's how you sell it. Best
Exactly.
mentor is
Yeah.
going to be over your shoulder. Can you submerge a tissue level implant with lowest primary stability? If it depends actually on the type of implant. So the older standard plus Straumann's you can submerge, but the problem, like you can submerge soft tissue wise, but if you place it too deep, you get bone loss down like quite a lot of vertical bone loss following the implant deep. If you use the newer IXL line because of the conical connection, the micro seal. So micro seal means like you've got the implant, you've got the abutment, and there's actually leakage at that gap between the implant and the abutment. So that's called the micro gap. And then as you chew, especially in bruxes, you've got movement, micro movements. That gap actually pulses, opens and closes, and there's a hydrostatic pressure that goes through the micro gap into the implant and around the soft tissues. So if you've got an implant that can manage the micro gap to very, very minimal, through the design of a conical connection seal, and there's a handful of implants that can do that, then you can place the implant deeper, tissue level or what not, and you won't get the bone falling down deep to your submerged deep tissue level implant because of the micro gap. Yeah. So it's very hard. I placed a very deep and submerged tissue level implant, and my restorative dentist like, "What did you do?" Because there's bone everywhere, and then they couldn't restore it, and then I had to go and cut the bone around around it, and I'm like, I'll never do that again. But yes, you can submerge it from a soft tissue point of view, but be careful not to put it too deep because bone just grows everywhere. Yeah.
It's a good
And
problem to
then
have.
not if you're the restorative dentist.
No, not if you're
When
the
when a patient asks how long an implant lasts, I tell them a hip replacement last 15 years. A dental implant, which is invented by an orthopedic surgeon, right, is the same material, it's the same concept. Per Ivan Brannemark started off with implants in the mouth because he could retrieve them and study them, and then went on that technology went on to the hip. So companies like Zimmer do both hip and teeth implants. I would say 15 years. And then if you're good conditions, you get more than 15 years out of it. Just like a root canal treatment, we say 10 to 15, but some people can get 30. Okay. But I say it's not without complications. 30% of patients will have complications. But if you come early with a loose screw or a chipped crown or a soft tissue abscess or a problem, and you come and tell one of us, the dentist, we can manage it for you. We can maintain and fix and troubleshoot that problem early so that your implant lasts longer. So that chat about maintenance is really important. And then seeing your patients long term every 6 months is important. Makes the implant last longer. There's a study, if the patient disappears for 10 years, they have a higher risk of the implant failing. Because you just don't have any supportive periodontal therapy. You're not managing their oral hygiene. You're not managing their soft tissue, their plaque, tartar, periodontal disease everywhere. Yeah.
Yeah.
So, yeah. So you can talk to them about how you can make your implant last longer by coming to see me every 6 months
That's
for
right.
a
You
SPT. Yeah.
get them to keep on coming back.
Yeah, that's
Yeah.
right. Is it okay to cover the preservation material gel pad? Yes and no. It depends on the scenario. So if you've got a dehiscence and it's a complex ridge preservation, not a good idea. But if you've got intact bone socket and you're just doing a simple preservation site, yeah. But you might not get the volume that you want. So in terms of vertical height, the difference would be that the gel tamp doesn't exclude soft tissue from going into your graft, whereas membrane will. So if you've got someone with huge amounts of soft tissue and bone, it's thick, but biotype really doesn't matter. But if you've got this site that's really, really super thin and every millimeter counts, then it's best that you cover your bone with membrane to exclude soft tissue going into your socket, because you'll find that you'll get a little bit less volume if you use gel tamp compared to proper GBR. So you can decide based on the case.
Yep. Perfect.
Oh, there are a lot of questions. When you say, when you
We've got
say,
about five, 6 questions
okay.
left.
All
Yeah.
right. When you say you want patients to keep implants for 10 to 15 years, what would a healthy individual with no implants lose? I tell them we don't run around looking your implant out. And I have seen my own mentors' patients with implants placed in the 80s. They're now 40, 50 years old. So they're 40 years. But I also tell the patients implants were invented in 1972. They're presented to the world in a congress in 1982. We do not have data more than 40 years. So we can't tell you what happens after 40 years. All right. So basically, we're like, you can keep your tooth till you die, but we don't have data to tell you what happens after 40 years. That's it.
Yeah. You're not allowed to say it's gonna last
Well,
for
we,
a
we
lifetime.
can't.
Yeah.
Like the implants with the studies 40 years ago are different from the implants now, right? So we only have 10, 15-year data.
That's right.
Sometimes only 5-year data for some implants.
Yeah. So what I tell my patients is you might keep the implant a bit longer, but you might expect to change the crown
Yeah. Yeah,
10,
yeah,
15
you
years.
might have to. Yeah, I have patients that are either going into nursing homes or they're coming at late 70s or 80s. Every tooth in the head's missing. Guess what's still there? Their implant.
That implant.
That
I
implant
told
is
you.
still good. So I'm like
Amazing.
so super impressed, right? Yeah. So I'm
So
making
good.
dentures, around their 3 standing loan implants when the rest of dentition is gone. And I'm like, this is amazing,
This is good. Yeah.
Yeah,
Yeah.
it's good. So some
The power
patients,
of
good. Yeah,
implants.
yeah.
All right. We got the next one here.
If you're going to do a type 2 placement, is it still beneficial to socket preserve? Generally speaking, when I take the tooth out, I look at the socket. So if the socket has thick bone, like thick means 1.5 millimeters or more on the buccal, then I tell the patient, look, I can not socket preservate, ridge preservate, and you'll be fine because you have thick bone. But if you want to, I can preserve. However, if the bone's less than 1.5 millimeters on the buccal, or you can see there's a dehiscence. So there is like a, vertical drop, in the buccal bone, that's a dehiscence, then I would preserve. So I actually look at the anatomy of the socket after I extract the tooth. So I tell everybody I might graft, but then I may not graft. At least they've got the quote, they know I might do it, and they understand why I decide to do it. Yeah. Which is basically buccal dehiscence or thin bone on the buccal.
Mm.
Yeah.
Mm.
or
Yeah.
anterior side. Like if it's a 1-1-2-1, everyone's getting a ridge preservation in my hands. I've got colleagues that do immediate implants though, so kudos to them. I'm not so talented. Yeah.
Yeah. I found like more my upper maxilla teeth.
Yes.
I'm definitely preserving sockets.
Yeah. Because you can guarantee there's going to be bone when you come back. Yeah.
There's always some loss of bone there. Yeah.
Yeah. When is a barrier membrane required? If the tooth had an infection, how should socket preservation be carried out? Am I okay? To Can I be open?
It's a
Uh,
big question. Yeah.
so basically, if it's an infected site, I don't use I don't use bovine. I'm trying to not say certain brand names. No bovine bone, porcine bone, or membrane, if it has infection that I can't clear out, or if it's purulent site, so active infection, pus, just not being able to clean it out properly, I'd use something like calcium sulfate. Okay. I'm not sure if I'm allowed to say what products
You're
are.
allowed to say whatever you want.
So I
There's
put
no
ethos.
sponsors here, so it's
Okay, I'd put ethos in if it's an infected site. Yeah, because you can actually it's bacteriostatic. Yeah. Um,
yeah, ethos is
so
a good one.
yeah,
Yes.
yeah. So definitely, yeah. If there's any question, any pus or any kind of you're not sure that you've got the bone all clean, then don't put bovine or porcine bone in there. It will just blow up.
And if you're not sure, you could always. There's no harm in not doing any grafting and then
Yeah,
revisiting.
that's right. So, but then,
Yeah.
like, I guess you've got to explain to the patient if you're a beginner, I'm not going to put anything in, but in 2 to 3 months, we're going to take a CBCT scan. We're going to take the scans. We're going to measure and plan it. There might be a possibility that there's not enough bone, and I have to refer you because you need, guided bone generation, unless you're really confident after you did the GBR on your pig's head. So, yeah. So you can
Yeah.
decide at that point, but tell them
Okay.
earlier. Yeah.
Yeah.
So
It's
they're
all
not
it's all
upset.
about the pre-operative discussion with your
Mm,
patients. You got to
mm,
know the whole sequencing, like Cecilia was saying earlier. If you know your next steps, start to finish, you can confidently talk to your patients about that, and they'll know. Okay, I might not be able to
yeah.
get this done today. We can do it next time.
Yeah. Or like if I don't do the socket ridge preservation, you might need guided bone generation at the time of implant placement. So you can just heads up. They will really appreciate it.
Yeah,
Mm.
we're nearly there.
Oh,
Just some
thanks. Thanks,
compliments
Blamer.
here from
Okay.
Justin there. More
If the
questions?
tooth have a infection, should ridge we have to call it ridge preservation. We're not allowed to call it socket preservation. Be carried out. Oh, that's the same question. So basically, if it's an infection, either no, don't put anything in, or put ethos in. And barrier membrane is required when there's a dehiscence, like a bony dehiscence, or when the bone is really thin. So, or if you take a CBCT at the time of extraction, so before you remove the tooth, you can actually predetermine whether the bone volume is going to match your prosthetic planning. And in some cases, before you take the tooth out, you already know that the angle of the implant, if you're not using a coaxial internal connections, southern implant, your apical part is going to be dehisced. So at the time of extraction, you actually raise a flap. You do ridge preservation inside the socket, but then you also add bone outside the socket apically, predicting that you'll need bone volume at the apex because you've taken a CBCT of your tooth and you know where the tooth is and you know the angle. Remember that's the slide that I showed you with teeth in, and you can see there's apical dehiscences. So you can predict that and graft it and augment it at the time of extraction, which then makes your implant simple. Yeah. So then you definitely need a barrier membrane then.
Mhm.
Yeah.
Good explanation.
Thanks. I don't know, the powers that be said don't call it socket because it's like
I mean, if you're
like a
preserving a
lathe.
socket, I don't know, maybe it's in the word itself, socket. You're not trying to preserve a socket.
Yeah. Because it's the ridge, not just the socket. Yeah.
Yeah. ARPA's not going to get you if you call it socket pres.
Yeah. You'd fail at a Viva. I said there was a yes, I am just a general practitioner. It's just like, you know,
Sorry
there's a
about that
big
earlier. Yeah.
no problems. You know, there was like this big poster on like billboard. I'm not just a general practitioner, and it was by the College of General Practitioners to say that like
Oh,
GPs are specialists in themselves. Yeah. So
that's nice.
yeah, it was nice. So basically, I had many mentors. I actually did special needs first. And so I was a hospital dentist for about 10 years in special needs, doing a lot of surgery. Then I went to England and I did 2 years as a resident. So we did, I've actually done, uh, so I've done things that are not dental. So I've actually harvested from the hip. We've done sinus lifts. We had pretty much a Bimax every week. I was on call for trauma. I've plated mandibles. I've assisted in like orbit blowouts. I took BCCs out. So this is apicectomies. Yeah, pretty much all max back scope, including cancers. We were there doing surgery or part of surgery as a team. So there was the senior house officer, the oral surgeon, and the max fax. So 3 tiers. I did that. When I came back to Australia, there wasn't oral surgery at that point. This is like 2008. Okay, that's when I came back from England. You have to do medicine. So I'm just like, no, I don't think I want to do medicine. So I'll stick with surgery. I actually went to a PROS course and I tried my best to do crown preps and go back to PROS. I couldn't, just terrible at it. So then I like, I'll stick to surgery. But if you stick to surgery and just doing third molars, it's very limited. So then that's when Richard came into my life and said, you should do implants because implants, as a general dentist, that's what he is as well. So he basically has done surgery, all the surgery part, and then pros. So you can do both surgery and pros. If you're prosthodontist, the downside, there was a Justin's a prosthodontist, and when I talked to my prosthodontist friends, they kind of sigh because they receive a lot of cases from general dentists that are just a mess, and they feel like their whole careers is just fixing people's mess. You know, it's stressful, it's messy, it's like laborious, and often the patient's upset on the first day that they come in because they have to um, fix a problem that honestly shouldn't have happened in the first place, but has happened, and that's their every day. To be honest, it's a little depressing sometimes when I talk to them. You know, my life is simple. Person comes in with a tooth missing, replace it with an implant, send it back, teach the person to restore it. Voila, it's beautiful. Yeah. Or I prefer to extract it myself and then place and then send off for restoration. Yeah.
Yeah, pros can be very stressful.
Yeah. And then postgrad diploma was my pathway. I'm Sydney Uni, but that's the only thing that was available at the time. We're talking, yeah, early 2000s. Now there's so many. So, you know, we're in GDR, go GDR. They're going to give you one in for 18-month course soon. So wait for it. Yeah. Also, it's not just the course itself, it's mentorship. You know, I brought my patient to my mentors to place the implants. And then 5, 6 years later, when I wanted to do the next procedure, I brought that, like I wanted to do like chin bone grafts from the chin. I brought that patient to my mentors. And then another case, I wanted to do sinus lift. I brought that patient to my mentors. So at each point in time, I wanted to upskill. I'd bring my patient to my mentors and I'd do the surgery with him. So it's like ongoing for a decade. Yeah.
It's very important to get that
The
mentor who's
mentorship. Yeah.
willing to
You can sit
help
in a
you.
course, but in the end, it's your mentor because you need someone in the room with you.
Exactly.
Yeah.
Yeah,
Yeah.
exactly. Um, let's see here. What are your thoughts on this? Is a big
Yeah, I use
question.
both. I use both. So I find
Yeah.
ethos is not as volume stable. So, for example, in your 21-year-old boy, that you're treatment planning to avoid placing an implant for another 5 years, you can't put ethos in. It's not volume stable. Where you're not going to see the bone still there in 5-6 years time. So I'd use bovine bone with membrane, right? If there's an infection, you can't put bovine bone in. You can't put particulate bone in. You'll get infection. So I'll put ethos. Okay. Um, what else? If there's an intact socket, so there's no bone dehiscence, then you can put whatever you want in. It all works, right? So I guess that's in a nutshell. You have to assess what the socket is, and then go from there. Use the product that fits the problem. You can't always just use one thing. Yeah. It's like when you have a hammer, everything is a nail. Can't do that.
That's right. We've got some thanks here. We've got thank you for the prayers. And we've got one more about your cadaver course coming up.
Oh,
Where can we
am
find
I?
more information here?
You'd have to. It's very old school. It's literally Richard Chan's running it, and there's 20 people that can join. And literally, you have to email Richard Chan at 007. I think richard.chan007 at
Is
gmail.com,
this
or
the
just
Nobel Biocare one?
yeah, it is. It's supported by Noble Guy Care, but we
Okay,
run
I
it.
found the
You
link.
see.
I'll post that in the chat now.
Okay. All right. Yeah. So we do sinus lifts, grafting, full arch, and soft tissue. Tino teaches soft tissue grafting. So from the palate, soft tissue grafting. And Lydia teaches sinus lift. That's how I learned how to do a lateral sinus lift, is in that course with Lydia. You can learn transcrestal sinus lifts as well, like, and what else? GBR. You can learn
That's a
GBR
very good
on the pig.
lineup. You got a lot
It
of
is good.
yeah. That's a
Yeah,
very good
yeah,
lineup.
yeah. It's been running for over 10 years, as I remember. Like, I did that course to start doing GBR. And then I did the course again when I wanted to do full arch.
Yeah,
Yeah.
that's a good one.
And sometimes people just come back to practice on the cadaver. So we get repeats just coming for the cadaver part.
Yeah, that's amazing.
Yeah.
Nothing beats a cadaver. Well, I mean,
Yeah.
besides a live patient, but cadaver's
Yeah.
the next best
Yeah.
thing.
You just need practice, like lateral sinus lifts. You need practice. You don't want to practice on your patients. So, yeah.
That's it.
Yeah.
I think that's it for our questions.
Okay.
All right.
Good job, everyone, for hanging back. How many people did we have on there? I
I
can't
think
see
we got to like
anything.
50. Yeah, 50 something.
Oh, that's a lot.
Which is pretty good.
That's good.
Yeah.
Okay. Well, 50
So
people for GDR would be fantastic, right?
exactly. Thank you all for coming. And our next webinar will be June the 2nd with Dr. Alex Kaminsky with predictable extractions, which will be part of your repertoire if you want to do socket preservation. So sorry, ridge
Ridge
preservation and your implants.
preservation.
I
That's
gotta
right.
get those
Good
wordings
job.
right.
It's a mouthful.
So keep your eye on your emails if you're subscribed, and feel free to let your friends know. The link is in the comments there for Cecilia's upcoming course there in Sydney there for the cadaver course. So and keep an eye out for our GDR implant course as well. So
Good
have a
job.
good night, everybody, and
Okay.
see
Good
you all
night.
soon.
Bye.